Okay, let's get this webinar started. Welcome, everyone. My name is Hugo Giambini, and we put together this webinar titled Global Perspectives on Orthopedic Research, Balancing Research and Clinical Practice. This was an effort from various partners, the ORS Scientific Communications Committee, ORS staff, the International Federation of Musculoskeletal Research Societies, or IFMRS, and the Tanzania Orthopedic Association, TOA, and it also supported by the Orthopedic Trauma Association. So again, a little bit of background on the organizers. We have Federico Moscogiri. He's the CEO of IFMRS. Albert Macha, an orthopedic and trauma surgeon from Muhimbili Orthopedic Institute, and ourselves, part of the SSC committee from the ORS, and Dr. Jay Mohan, the Advocacy Council Chair at the ORS. So this webinar gives you a glance of what goes on at the ORS. There's many different activities at the Orthopedic Research Society that goes on, webinars, awards. You have chance to participate and organize this type of webinars, engage with scientific community at the annual meetings or offline, travel, research grants, fellowships. So this is a good opportunity for those that are not members to take advantage of becoming a member of the ORS so that you can interact with the scientific community and get the most out of the organization. So the ORS is proud to be a member society of IFMRS, which is a global alliance in MSK or musculoskeletal research organizations with 28 members, societies, and 8 affiliated organizations from all over the world. The IFMRS has been leading a lot of activity in the area of education in MSK research over the last 5 years, with great participation and input from low and middle income countries in particular. So I would encourage you to take a look at the website. It's over there in the slide for more information that you can gather on the Federation, and there are many resources that include global action plans on education and MSK research. So moving on to our webinar, we have 2 excellent speakers. Dr. Alexander Schade, he's a research clinical fellow from Malawi-Liverpool-Wellcome, Warwick Trauma and Orthopedic Registrar, ST6, University Hospitals, Coventry and Warwickshire. And we also have Dr. Roger Cornwall. He's a professor of orthopedic surgery and developmental biology. He's a research faculty director at Division of Orthopedic Surgery from Cincinnati's Children's Hospital Medical Center. So we are gonna see and listen to 2 great talks from these 2 clinical researchers. So let's welcome them, and we're gonna have Dr.
My name's Alex. I am a trauma and orthopedic resident in the United Kingdom, and I also did my PhD in Malawi at the Liverpool-Wellcome Trust, where I'm still a clinical fellow. So thank you so much for inviting me this evening. This is the second time I've spoken with Federico when he asked me, so it's a real pleasure. So I thought I'd talk a bit about my experience, I guess, of just balancing research and clinical practice. I thought I'd focus it a bit around some of the frustrations of kind of having these 2 careers and some of the personal lessons from it, and then how I've managed to balance the 2. So to start with some of the frustrations of doing research, this is in Malawi, one of the poorest countries in the world. Money is an issue. Research costs a lot of money, and in this environment where there's very little, everything costs a lot because you have to do it yourself. So even a support letter from a hospital costs $150, and 10% of your research fees have to go to COMREC, which is the ethics board. And there's also the constant renegotiation that's happening all the time. So that's really challenging. And you're starting off from not much at all. So if you look at the systematic reviews and a lot of the topics that I do, kind of injury or musculoskeletal disease in low-income countries, there's very, very little. So you don't have these other big studies and there's lots of data to kind of bounce off on. And the data, any data that you plan on publishing needs this approval, and that can take a real long time, 6 months, a year to do. There's no registries. Most hospitals don't have X-rays, and there's very few labs in this setting that can actually do any sort of microbiology. There's some of the pictures that you can see from on the right-hand side. This is what kind of a registry from a hospital looks like. They'll just say soft tissue injury or a bone fracture, but there's no details around it. On the bottom left is an X-ray that from a patient that had a tibial fracture and a pin put in, and they'll just twist it. But this is not really a view that kind of meets any sort of radiology standardization. So it is challenging to do it in this environment. But the benefits far outweigh any of these frustrations. And a lot of research is done in high-income countries, and a lot of practice in low-income countries is based on high-income country evidence. Not only that, but a lot of the authors from low-income countries are not recognized. So I think in our field of musculoskeletal science, we have a real opportunity to do it better than everyone else before. And the situation over there is not good enough at the moment. You have the motorcycle epidemic is completely rife in sub-Saharan Africa, and you have 100 patients awaiting emergency procedures. So just doing the same thing over and over again is not good enough. And we need research to do it better. I quite like the Lego analogy. When you go to kind of governments or stakeholders, you can't just go with a story of, I've got this patient that's suffering. You need data. So we need data to actually improve this situation. And getting those numbers is more sustainable as well. If you look at some of these pictures on the left-hand side in the middle, that is a picture of one of my master's students that was speaking with the Malawian parliamentarians, presenting the data to actually make sure that they had proper injury policies. On the bottom left is a picture of the maternal deaths in a district hospital. So these are district hospitals that have no data, no research, but because the WHO is really looking into maternal health, they're closely monitoring this, and actually a lot of women are going to the theatre to have cesarean sections. So it's by data that you actually change practice. Some of the lessons I've learned is that in order to do research in this type of environment, you have to plan long term. It takes a long time to get ethics. It takes a long time to actually set up when you have very little, and it's all about the people. So some of the pictures at the top are, on the top left is one of my PhD supervisors that was living in Malawi for 20 years, and he has that network of people that you can build on. On the top left is Sven Young and Leonard Banza, who are two orthopedic surgeons that work in the capital city, and they've just opened a $46 million trauma center over there, and that is the ground before it built on. It's these type of relations that you actually need to develop over a long time. Rigorous research methods matter. If you're going to do it, you need to do it properly. And actually planning everything beforehand, during the study, and then with careful analysis is how you actually do it properly. I also think that we can't only think as clinicians. You need to create a diverse team around you. You need health economists because money matters, and if you can show cost effectiveness, it's going to go much further. You need microbiologists that can do the basic science in the lab, and you need clinicians that are out there with the patients. So you need to think broadly, and you need to think properly. Moving on to some of the clinical work over there, infection is a big problem. It's because it's multifactorial, but it is really challenging. So if you are going to operate, you have to make sure that it makes a difference. There are lots of cases, unfortunately, that get infected. The picture in the top middle is an open tibia, that was a horrible motorcycle injury, and that was fixed with an external fixator, and all the skin just broke down, and then it got infected. The lack of C-arm, which is the getting X-rays in theatre, and poor quality radiology is a real challenge in this environment. When you're putting plates and screws without any imaging, you're having to compromise. Also having very poor quality radiology really impacts clinical decisions. So sometimes it is a really challenging environment. And also non-operative management can be done really badly over there. So the pictures on the bottom left is that someone who's had a humeral fracture, and sometimes this can be amenable to non-operative management, but unfortunately, if it's done badly, they can end up with non-union. This can be really debilitating for patients. The pictures in the middle are someone who's had an ankle fracture, and typically you need to put a bit of wool before you put the plaster on, but here they put the plaster on first before the wool, and typically you can get really bad ulcers, and well, in the bottom right is infection. But again, these frustrations should not put people off. There are incredible teams of really hardworking orthopedic surgeons over there. And on the top right is Cornelius, who works in the capital city, and the patient there is someone who had a a femoral fracture that went into not uniting. And he was a farmer. He couldn't harvest. He couldn't work, and he had an intramedullary nail put in. And he was so grateful. He actually brought a live chicken to clinic to give it to his surgeons. These patients are really grateful for management that works. And the picture on the left-hand side is something we don't see that much in high-income countries. The pathology is very advanced. So this is someone who's got really osteopetrosis, really hard bones. They broke their femur, they broke their tibias, and we underwent bilateral tibial nails and bilateral femoral nails. But it is all about the local surgeons there that you work in collaboration with in the teams. And some of the lessons I learned from working clinically out there, it's really important to be humble. It's a really challenging environment. And on the top right is two of the consultants in Blantyre in the south, and they were incredible to me. I'm an orthopedic surgeon, so I have orthopedic knowledge, but I don't do that much plastics. But those surgeons there have much more diverse skills, so I had to rely on them a lot of the time. Keep it simple is a very good thing when it comes to working out there when it's challenging. So if you don't overcomplicate things, it can go horribly wrong. And if you can do surgery, such as an medullary nail, those often do work for certain injuries. I've added a few slides about just actually, I was living there for 3 years. Some of the experience of actually living in a sub-Saharan country as a clinician that also does research, it can be quite chaotic. So on the picture the top right is someone that was driving about 100 kilometers an hour on the road with the boot open. Then the car was full of people, and there's someone actually stuck in the boot. The picture in the top middle is someone that's trying to pay his driving license with a fish. So these things are just, you see this all the time. The country does not have enough energy or petrol, so there's a lot of power cuts and water cuts, and not having mobility when you're trying to run a study in 6 hospitals can be challenging. And the video is of a tanker followed by motorcycles that's just entered the country. So everyone's desperate to try to get any fuel to actually be able to travel in the country. So that is picture on the bottom left is me queuing at around 1 a.m. to try to get a bit of fuel in my car so I can actually go to some of the district hospitals. And the climate crisis is having an impact in Malawi. This is a country that is hit by cyclones. They used to occur every 3 years, and with global weirding, they're occurring more and more commonly. So it's not uncommon to see crocodiles on houses. And the picture from the bottom left is a couple of years ago when we had a cyclone hit us. These are some of the challenges that you have to face and trying to run a study in lots of different hospitals when there's, cyclones, no fuel, no electricity. It can be challenging, but again, the benefits far outweigh any of the challenges. And the people in this environment are so friendly and wonderful. My colleagues, my friends, is very, very rewarding. And the weather we don't have a cyclone is quite warm and a lot more light than a lot of the northern hemisphere. And the wildlife in the setting, it's incredible. And so even though you work pretty hard during the week trying to do your research and be a clinician on the weekend, you have a very relaxing environment. So this is where you can do your data analysis as a researcher. Anyway, I think you get the picture. Some of the important lessons from over there is it's really important to integrate. The local language is Chichewa. So I had lessons for 2 years. So I could speak to patients, so I could speak to the staff members, and it's really important to integrate. Pangono is Chichewa or Malawian for slowly, slowly. A lot of things just over there happen slowly, and you have to be very patient, and that's just a way of life, and you have to embrace it. Because if you do embrace it, it's just so much fun. So how do you actually balance being a clinician and being a researcher over there? It's important to be very organized. It's like these jugglers that are chucking 100 balls up in the air, and you're having to manage kind of catching one and not the other ones to fall. But I think actually having this balance with all these balls in the air is really healthy. If you're getting fed up with something or something's not working, you can switch to another challenge. But again, having a good team, whether you're communicating through WhatsApp or having project officers and having a team around you that can support you, really helps balance these two. This is what my weekly timetable looked like from Monday to Friday. It was split about 40% clinical work, and then 60% research. But you end up working more than that, including the evenings and the weekend. But I think this was the balance that I managed to find. So what does the future look like? In the UK, after your PhD, you have opportunities with NRHR, which is the research body of the NHS or National Health System, where you can balance 50-50 with your clinical work and your research. Or Wellcome Trust also has early career awards and different grants that you can apply for as a postdoctoral fellow. The next step for me is to do a randomized control trial and see if it works initially with a feasibility trial, both in district and tertiary hospitals. A lot of the evidence from these environments are only from tertiary hospitals, but you can't look at trauma and musculoskeletal disease in low-income countries without actually taking the whole picture and looking at district and tertiary hospitals. It would be also interesting to do it as a multinational collaboration with different countries and using the networks of, I believe, one of the previous speakers, Grace Drury, mentioned CASEXA, which is the College of East African Surgeons, or WACS, which is the College of African Surgeons, and using these huge network that they have throughout the continent to actually see whether the interventions can be applied very widely. So that's it from me. In conclusion, research is an integral and key part of sustainability of orthopedic care in Malawi. You can't separate clinical work and academic work. It is possible to be sustainable, and this is done by the relationships of the people over there. And I believe the key to balancing an academic and a clinical career is through having a good team of people around you and being very organized. So thanks again for the invitation. I'm happy if you have any questions about that. That's my mobile phone number and that's on my email. I'm always happy to be contacted. Thank you.
Excellent. Thank you very much. So let's now introduce Dr. Roger Cornwall and listen to his presentation, please.
So I'm Roger Cornwall. I'm a pediatric orthopedic hand and upper extremity surgeon at Cincinnati Children's Hospital, and I also run a lab that focuses on the molecular biology of muscle growth as it pertains to neuromuscular contractures. I am also representing the ORS as its current second vice president, and I'm proud to do so. Today, I'll be talking about lab-based research as an orthopedic surgeon scientist, so it won't be as specific to Africa, but it will be specific to lab-based research. And this is a particularly tricky thing to do, and it depends on a number of different resources, and that is something that I'll be going over today. Also touching a bit on some of the research that I've been doing as a way to demonstrate some of the principles. I have no relevant financial disclosures. The other thing is there are some videos in this talk that may or may not work on Zoom here as we're seeing we're having some technical difficulties. But I'll see if the points will still come across. I have no relevant financial disclosures other than some research funding from a variety of generous sources. I also must disclose that I have no financial relationship with Volvo Trucks. Also, I do not have a PhD, and so in the lab space, I do have a bit of imposter syndrome, and I think it's worthwhile to say that out loud to help normalize conversations about the importance of mental well-being in what can be a difficult career. And I'm happy to talk about that at any time with anyone, but for the purposes of this talk, suffice it to know that I am not Jean-Claude Van Damme. And if you're wondering why I'm talking about Swedish trucks and Belgian martial artist actors, it's not because I'm trying to keep this as a global perspective, but rather because my job today is to teach you to do the most epic of splits. The most epic of splits. So this video, which is taken from a Volvo truck commercial where they're highlighting the precision steering, note that these trucks are driving backwards, which is a hard thing to do. This video has been picked apart all over the internet with naysayers saying that it couldn't possibly have actually happened, this must be computer graphics, etc. But it actually did happen. This was done in one take on an airstrip in Spain with this guy, Jean-Claude Van Damme, doing these splits on these trucks. It actually is possible. But the video has not been picked apart, at least to the best of my knowledge, as an analogy for lab-based research as an orthopedic surgeon scientist. Although if anyone on this webinar has done this, you might empathize with Jean-Claude in this particular instance. But let's do that today, and starting with the trucks, representing the clinical world and the lab world. And we'll start with the clinical world. Why? Because the quality of your clinical care is your highest priority. Full stop. Patient care cannot suffer as a result of your research efforts. So, if you're going to put one foot in the clinical world, that foot needs to be firmly planted, meaning you need training. I often get questions from folks who are going into their fellowship year, asking about how they build or sustain a basic science effort if they have an interest or they maybe even have some basic science work already started. And my response to that is don't worry about the basic science. Worry about your clinical training. What your job is in that year, and this is true in residency or even early in practice, is to become the very best hand surgeon or spine surgeon or arthroscopy surgeon you can possibly be. So your science career should not interfere with that. And then you need to practice the clinical skill. You need to have repetitions in the operating room to keep your skill up. You need to be seeing patients in the clinic and learning from those encounters. And when you're not in the OR and when you're not in the clinic, you also need to be available to your patients. You can't vanish into the lab world. But you do have to actually go to the lab, which means you also need a team to help you manage the clinical practice. You need leadership who support your time in the lab by compensating you for it, or at the very least, not penalizing you too severely for it. You need partners who are going to take care of the surgeries that come up while it is your lab time, also supporting you spending time in the lab. And then, of course, you need your clinical support team. You need nurses or perhaps mid-level providers, administrative assistants, medical assistants, whoever you have in your team to help communicate, to help take care of the patients, because you can't be answering all of the phone calls and you can't be scheduling your own clinic visits. And then you need infrastructure. You need a good truck. You need facilities to be able to take care of patients. You need operating room time and clinic space. And you need the clinical services that your patients are going to require, such as casting and whatnot. And it's important to have the right amount of clinical volume. This can be tricky. There are some circumstances where the clinical volume is overwhelming and it makes it very difficult or impossible to get away to the lab. But on the converse, there are also environments where the clinical volume is not enough, and you might have to spend time, scrounging for patients to build your practice. And you can't do that at the same time that you're building a lab. And so having an appropriate clinical volume is very helpful. And then you need all of the specialties that are going to be necessary for taking care of your patients. And I say this because if you're trying to do lab-based research as an orthopedic surgeon scientist, chances are it's because you like to do hard things. And that usually means you're taking care of difficult clinical conditions such as oncology or complex congenital or developmental problems. And so you need all of the various specialties that are going to be able to provide all of the care that these patients need. So let's move now to the lab world. Well, again, if you're going to be planting one foot in the lab, that foot also needs to be firmly planted, which means the quality of your research matters. You need the knowledge and skills to be able to do the lab research well. And you can get that knowledge by getting a PhD or doing a postdoctoral fellowship, or perhaps learning on the job like I have been doing, working with mentors and collaborators, or going to the ORS to the meetings, to the webinars, to the Learn ORS platform, many resources there to learn knowledge and skills for basic science research. But then again, you have to keep practicing it and you have to keep learning because new techniques will come on board. It may be difficult to believe, but when I started my lab, whole genome RNA sequencing was not a thing. CRISPR was not a thing. These are tools that we use all the time now, but those weren't available just 15 years ago. And then again, just like the clinical team being available to your patients, you have to be available to your lab team to keep things rolling. Even if you're busy clinically, you need to be able to check in with them to make sure that the research is moving appropriately, which of course means you need a team. You need people driving the lab truck. And that includes mentors, not just people you go to for questions or problems, but people who are going to actually promote you and promote your research career. You need collaborators. You can't do all of it yourself, and so you need to bring in collaborators with appropriate skill sets. And then it's very, very helpful to have your own lab team. And that can look any way you like, depending on the resources that you have available. I've been very fortunate to have a couple of postdoctoral fellows who have stayed on as faculty and have been running the lab on a day-to-day basis with research assistants and then with students. And in my lab, it's primarily undergraduate students and medical students. You could have postdoctoral fellows or grad students, whatever works well in your system. But having your own team that's dedicated to your own lab's work is really very, very helpful. And then, of course, you need a good lab truck too. You need the infrastructure there. You need lab facilities. You need the space at the bench. You need all of the equipment and freezers and whatnot. And then the services, such as histology services or maybe transgender animal services, if you're going to be doing that kind of work. And then it's important to have a critical mass of research volume. And that is, that if that's in the Department of Orthopedic Surgery, that's fabulous. But if it's not, you can find it elsewhere. So for instance, at Cincinnati Children's Hospital, the critical mass of research volume that is relevant to the work that I'm doing is in the Division of Developmental Biology and in the Heart Institute. The heart is a muscle. I do muscle research. So that's where all the muscle research, almost all the muscle research is being done. And so that's where my lab is. That's where my collaborators are. And then you need the appropriate disciplines to help. Again, you can't do this all on your own. And so if you need molecular geneticists or you need bioinformaticians, you need to be able to contact people who will be able to help. And they don't necessarily need to be at your institution or even in your country. I have collaborators in Finland that I work with on a regular basis. And so that's kind of a broad overview of what you need on the lab side. But if you're going to pull it all together, we also need to talk about what you need in you as the surgeon scientist. And I'll start off by saying core strength, right? You're not actually holding two trucks together, but you're holding two very different careers together. And there are two concepts that I think are very important to consider when thinking about holding all of this together. One of them is finding content synergy, and the other is sharing across the worlds. What do I mean by finding content synergy? Well, basically, it means the trucks are driving in the same direction, right? If you have trucks that are going in opposite directions or diverging, then it's going to be very, very difficult to keep that together. And to illustrate this, I'll spend a couple of minutes talking about some of the research that I've been doing, which shows some examples of the interplay. So as a pediatric hand and upper limb surgeon, I take care of children with brachial plexus birth injuries. So a difficult delivery can involve a shoulder getting stuck on the way out of the birth canal, which injures the nerves of the brachial plexus, leading to paralysis of the arm, and then eventually contractures of the arm. And the most notable contracture in the upper limb is the internal rotation contracture of the shoulder. So you can't turn the arm out to the side, even passively. And historically, we have thought of this very simply as a problem of muscle imbalance. Not every nerve is injured in the brachial plexus, so not every muscle is paralyzed. So you have functioning internal rotator muscles that overpower paralyzed external rotator muscles, leading to static internal rotation posturing and ultimately a contracture. And that makes a lot of sense. And if that contracture is bad enough, you'll end up needing to do an operation to release it, and that involves releasing the subscapularis muscle. That's the muscle that gets the tightest, one of the muscles that internally rotates the shoulder. However, when I was starting my practice in about 2004, it was becoming apparent that releasing this muscle was leading to the opposite problem. Now where children can't bring their arm back in and do buttons and zippers and other activities of daily living. And this was turning out to be a real problem. And I thought, I can solve this problem because when I was a resident in New York City, there was a shoulder surgeon doing total shoulder replacements who encountered the same difficulty. And he came up with a solution for it there that I could apply to these children. And that solution was to just cut the top part of that tendon, the subscapularis tendon, and that would allow more movement in the subscap, and it would preserve the lower part of the subscap attachment, and so there would still be active internal rotation function. And so I thought, this is great. I can do this in these kids. I started doing it, and sure enough, it worked. I was relieving the contractures, and preserving internal rotation function. And I was so excited about this. Yes, I solved this clinical problem. The problem was that it made absolutely no sense why it worked, because the upper subscap muscle belly is innervated by part of the brachial plexus that's injured in a typical pattern, and the lower part is innervated by a part of the plexus that's working, which means I'm only cutting a denervated muscle. So why would that relieve the contracture if it's supposedly the functioning muscles that are causing the contracture? So that brought up the notion maybe it's the denervated muscle causing the contracture, which brought up the hypothesis that denervation at birth impairs longitudinal growth of the muscle. So the muscle ends up getting too short and thus tight as the skeleton grows. And if that's the case, and if we can figure out the biology of that growth impairment, we can correct it medically. Meaning instead of doing surgeries on these kids, we could come up with a medicine to cure the contractures. And that got me very, very excited. And so I needed to start a lab to figure this out, because you can't do the experiments necessary to test this hypothesis in humans. And so go over to the lab side now. And I started it by developing an animal model in mice where you take out portions of the plexus that leads to the appropriate paralysis and then contractures. And with these contractures, with this model, I was able to demonstrate that indeed the neonatally denervated muscles were not growing in length appropriately. And that impaired length, or the failure to add sarcomeres, or the elastic units of muscle, meant that the sarcomeres that were there had to be overstretched. And so that was the hallmark of these muscles that are too short. They're overstretched. And I was very excited because this was in line with the hypothesis. And then people would say, yeah, but that's mice, right? What about in humans? So we went back over to the clinical side, and we found that same sarcomere overstretch in human patients with these contractures. And that was very exciting, because now we had this sense on the clinical side that we could explain why these contractures would get worse as the children grow. And we could explain why you do all of this stretching and then the contractures come back. It's not a failure of the treatments, it's just a concept of the biology. So then we think, okay, well, now we just need to figure out how to correct that biologically. But the trouble is nobody knows what regulates muscle growth in the first place. And so we go back to the lab to figure that out. And so fortunately, after 5 years of research, we were able to identify that the muscle isn't growing properly because there's too much protein breakdown in that muscle and protein degradation. Muscle protein is being made, but it's being degraded too fast. And importantly, we found that if we inhibited protein degradation in these mice, we could completely correct the contractures. As a proof of concept that indeed it's a biological problem amenable to medical therapy. So that was the big eureka moment in the lab. However, the problem is the medications we were using in the mice are far too toxic to use in humans, because they're inhibiting a very important process of protein degradation. So we need to more carefully refine what is happening in the muscle so we can target it more precisely. And so we got a little bit stuck. But in that situation, we can go back to the clinical world and we can get clues there. So there are circumstances. So most of the time when there's a plexus injury, the nerve roots are injured after they've come out of the spinal canal, and it's a complete rupture of the whole nerve. But there are some injuries that are rare that occur at a different location in the nerve, preganglionic, they're called, where it's upstream from the dorsal root ganglion. And that preserves afferent, or the sensory, as well as the sympathetic innervation of the muscle. And that's not really important, but what's important is that these kids with this injury do not get contractures. And so that's a clue. Maybe there's something different about the biology in these muscles that's leading one denervated muscle to get a contracture and another denervated muscle not to get a contracture. And so we go back to the lab with that information and create these injuries in the mice. And sure enough, when you create these preganglionic injuries, they do not get contractures, which then allowed us to compare the pre and post-ganglionic injuries along with other conditions using RNA sequencing to identify genes that are specifically regulating muscle length, which is something that no one's been able to do before without this clue from the clinic. And in that group of genes, there is one particular gene that also modifies the severity of contractures or problems in Duchenne's muscular dystrophy, for which there is a drug currently in clinical trials that we could apply then to brachial plexus birth injury, even in just a few years. And that is very exciting to me as we think about this clinical problem that otherwise has no good solution. And so you can see just from that example that there is an interplay between the clinical and the lab world that can work extremely well. And then if you share that across the worlds, that's even better. I can take students from the lab into the clinic and they can see the children in these families struggling with contractures, and they are so inspired by seeing this and the effect that they may have. And by the same token, I can talk to patients and their families in the clinic about the discoveries in the lab, and that inspires them as well because there's hope on the horizon. It may not help them, but it may help children that are yet to be born, and that is still inspiring for the patients. And then also, you need flexibility, and not hip flexibility for doing splits on trucks, but mental flexibility, because there are very different mindsets in the lab and in the clinic. And for instance, in clinical work, you really rely on knowledge or predictability or certainty to provide the appropriate treatments, whereas in the lab, you need to revel in uncertainty. That's where the questions are. That's where the curiosity is. And also, you need to have a different tolerance of failure. Clinically, there is no way you'd be excited about providing a treatment that fails 90% of the time. But that's lab work. It fails 90% of the time. It could take months of optimizing an experiment or years of getting a transgenic animal model to work the way you want. So you have to have a very different tolerance of failure. And then finally, you need passion. Your heart needs to be in it. You need a passion for your true north. My true north is curing these contractures. Your true north could be solving a different clinical problem or developing a diagnostic tool or changing outcomes or even just exploring to identify new knowledge. But being passionate about your true north is what provides the perseverance to get through all of the failure and also provides the fulfillment. Because if you pull this all together, I assure you that this career of as a surgeon scientist can be beautiful. And there's a video to go along with that, but we'll stop there. Thank you.
All right, thank you very much, both speakers. Excellent presentations, very informative. This is for Alex. Very impressive presentation and job you did in Malawi. Importantly, you mentioned sustainability at the end of your talk. What can you do to identify local partners and set up a sustainable relationship to devise and then embark on a joint project that fits the region's need?
Thank you so much for the question. I guess the question has two parts, first of all. I guess it's identify, and then the kind of the question about how do you identify or how do you develop a research question then that's locally appropriate. And it is a brilliant question because, and I think one of the things we need to talk about in the context where I do a lot of my research is white man syndrome, where you go in with preconceived ideas, thinking that you will solve very rapidly solutions, and there's an inherent suspicion of people that come like with those ideas. So I would say the first thing is it takes time, but I think you need to. So sorry, to answer the question. So it takes time. I would suggest to contact kind of local stakeholders and people that have been in the area for a very long time. So, for instance, for myself, one of my mentors, my PhD supervisor, lived in Malawi for 12 years and goes very regularly. So, or the Liverpool-Wellcome Trust has been there for 25 years. So they've developed long relationships with a lot of people. And initially, when I was going there, 5-10 years ago, you have to be humble and just observe the problem and be keen to learn as much. And I guess Dr. Cornwall talked also about just being curious for kind of local solutions. So partner with stakeholders and the local people, and then eventually you'll identify a couple key people that are a bit more research minded and that you can bounce ideas off. And I think to answer this, the second question about, I think about how do you develop a research question that is, locally appropriate. It's needs assessments and consensus meetings can be very helpful. So, for example, my PhD was on open fractures, and the Lancet Commission on Global Surgery prioritized this injury because a consensus group of people felt it was very important. And then we went out there, and all the researchers said it was really important. And then we analyzed a fracture care registry of 24,000 patients, and they showed that open fractures were more likely going to be operated on, but we didn't really know those outcomes. So you gather the evidence from the experts, from the local people, you gather from kind of the little data that you do have, and from there you build on locally appropriate interventions. So I think that's how I'd approach it.
So I'll ask a question here. Dr. Cornwall, you touched a little bit on this, but could you maybe expand, and then Dr. Schade too, on how or what advice you give early career clinicians who want to develop a strong research profile, let's say, considering the different scenarios that you've described?
Yeah, that's a great question and a fairly common one. And I think it's important to really understand who you are as a person when you're trying to think about your research career and how you want to balance it. That everybody has different motivations and different interests, and you could look at work that other people are doing and think, I want to do that kind of work, but maybe you're not passionate about the subject. And so I think it takes a little bit of time to sort out what your true north is, because that's what's going to really guide you in your career. It's not a straight line, and to have an idea of what it is that you want to accomplish with your career really helps you stay on target as you're meandering along that line. So that's one important thing, and it also helps when you sort out what kind of work that you want to do, where you're able to do it, because each if you think of, different seeds need different kinds of soil to thrive and germinate. And so someone who might be very interested in clinical research might not thrive in an environment where there's mostly basic science research being done, or vice versa. So I think taking some time to really understand and reflect on what it is that drives the desire to do a research career will help answer that question. First, know thyself, a very philosophical principle.
Thank you.
I would echo what Dr. Cornwall said. I think knowing yourself is quite, but also, yes, knowing yourself is a very important part of it. But just the caveat to that is you described early career researchers. I'd probably call myself one of those, and I definitely have imposter syndrome when it comes to that. I think you have to be, as he said, passionate and curious. I think you kind of have this 50-50 split career, but then inevitably you end up working kind of 80%. So a lot of it kind of is in your spare time. But if you're passionate about it, then it feels less like work, and you're always kind of happy to do more, and you're hungry for more. So I think if you enjoy it, it will feel less like work. And I think maybe advice for early career researchers is, if just because a professor thinks it's interesting, you might not be interested in it. So I've had incredible mentors throughout my career that have believed in me and believed in my research. And I don't do basic science. I knew I didn't want to do basic science research during my PhD. And I told my mentor that, and he believed in me. So he supported me kind of to do all the research. So I'm very grateful for that. So you want people that believe in you and that will support you to kind of achieve your own kind of passion and your own curiosities, rather than just what a certain professor finds interesting.
Excellent, thank you. So this is for Dr. Cornwall. The drug which was used to treat contractures in mouse, what was the mechanism? Did it increase protein degradation or restore the length? Can you expand on that?
Sure. Yes, it was so there was a whole class of proteasome inhibitors that we used that decrease protein degradation. Do not use them in children. They are not approved in any country, as far as I know, for this indication, and the toxicity outweighs the potential benefit. So I have to say that as a surgeon, do not use those kinds of drugs, even though they're available for cancer treatment. We have now 3 other classes of medications that also have a similar effect by restoring growth and preventing the contractures, but still nothing that's specific enough to be safely used in humans.
So this is for Alex. Is there currently a link between the ORS orthopedic trauma work that is happening in Malawi and emergency medicine specialist doctors?
So yes, there is. There's a lot of work in emergency medicine that's being done in Malawi. The World Bank has invested quite heavily in pre-hospital medicine and emergency medicine. So there are emergency medicine registries that are kind of developing there. But the government, the Malawian government, is very much interested in emergency medicine as well. The biggest stakeholders are probably AO Alliance is an organization I work with. They've been working in Malawi for 20, 30 years in injury care, and there's a lot of overlap between emergency care and orthopedic care. So World Bank, AO Alliance, but there's also different universities that are interested in emergency care. So there's lots of partners. But it's still completely unknown. There's still loads and loads of work to be done. But yeah, if you just message me, we can chat about it more.
Yeah, the question. I'll jump in with one here. Okay, I'll jump in. We've seen the presentations that you talked a little bit about research and clinical practice, but could you expand on what your thoughts are in regards to what the research priorities differ or how those differ between low and high income countries or based on low high income resources in terms of priorities?
Do you want to
Alex,
start?
why don't you take that one? Yeah, go ahead and take that one.
So there are some research questions that will be applicable to both, but I guess your question is about how to prioritize, and obviously the populations are very different. The median age of Malawi is 16 years old. The median age of the fracture care registry of 24,000 patients was 14 years old. It is a predominantly pediatric population. So there's a huge amount of pediatric work that needs to be done in that setting. In lots of high-income countries, we have low birth rates. In my UK trauma practice, we end up treating a lot of hip fractures in 80 and 90-year-olds. That is the priority in high-income countries. The priority in low-income countries is very different. The resources will be infinitely different as well. In that in high-income countries, we are able to do a lot of elective work, whereas we know that 90% of road traffic injuries occur in low and middle-income countries. So there is just trauma. Trauma is such a priority over there, and it's very different to, a lot of the degenerative diseases that we have in high-income countries. So the people are different, the pathologies are different, and I guess that relates to the question that was asked initially. You need to do a needs assessment to see, and gather evidence to see actually how to prioritize things.
I would add that I think from a clinical research standpoint, we don't yet have a very good understanding of what the priorities are for our patients. And that's true in high-income countries for sure, where we're identifying in certainly in brachial plexus birth injury, that the family relationships are a bigger driver of overall global health than any physical examination factor that we could operate on. And so I think we have a lot to learn about clinical outcome priorities from the patients and families themselves. And that's something that embarrassingly we have not yet done a very good job of, even in very, very well-resourced countries. And so I think if we are to look at what might be different among different situations and what might be similar, that would be an area that's ripe for research.
Okay, well, I think we're right on time. I want to thank you both again for the wonderful presentations, very, very informative. And thank you again for participating in this webinar, and thank you all for attending the webinar and being active, asking questions and listening to the speakers. So thank you very much.